My name is Mike, fourth-year resident here. Thanks for coming. In the last 12 years, the landscape has changed in the management of metastatic and advanced renal cell carcinoma. It was a surgically managed disease where the role of cytonephrectomy had a significant role. Since targeted molecular therapies have been developed and studied, they offer a significant improvement in prognosis. And a critical question we don't know at this time is the role of systemic therapy in advanced metastatic renal carcinoma in the surgical setting. Today, I plan to talk about a couple of things. First of all, I'd like to review cytoreductive nephrectomy in the molecular targeted therapy era. I'd like to look at the effect of targeted therapy on the primary tumor in unresected disease and its benefits in being able to convert an unresectable disease to resectable. I'd like to talk about the safety of the surgery after being on targeted therapy, the risks and benefits of neoadjuvant therapy, as well as adjuvant therapy. And lastly, I'd like to review some available clinical trials here at VGH and how to get accrual for them. I'd like to start with a 71-year-old female. She had a 20-centimeter renal mass. She had a horseshoe kidney. She had some baseline renal dysfunction, 2 liver mets. And you can see this tumor is massive. And before you consider surgery, you have to wonder what benefit you're going to offer this patient with a major surgery. Well, in 2001, both the SWOG and the EORTC released randomized controlled data stating that there was a significant overall survival benefit by offering cytoreductive nephrectomy. They said that you could improve median overall survival by approximately 5 or 10 months, depending on which trial you look at, in good performance status patients with metastatic disease. However, cytoreductive nephrectomy is a major surgery with significant morbidity, and the survival benefit is modest. So this was evaluated prospectively, retrospectively. Here's SEER data on over 5,000 patients with metastatic disease in the immunotherapy era. And of those, we noticed there was a 2.5-fold greater overall survival and cancer-specific mortality. You notice that there's a 22-month versus 17-month overall survival benefit in the cytoreductive nephrectomy patients. You need to consider that this has significant selection bias. The patients who underwent surgery were obviously pre-selected to have better performance status. They did do a multivariable analysis, and they found that performance status and increased comorbidities did not correlate, but it is a consideration. The CULP in 2010 released his look at a retrospective data on 110 patients who did not undergo cytoreductive nephrectomy and compared this to 73 patients who did. He looked to see if he could predict, is there any way we can predict who will benefit from cytoreductive nephrectomy? He's found 6 variables that are based on preoperative laboratory data that are associated with decreased overall survival at the time of cytoreductive nephrectomy. There's another group, Fertlet, that did the same sort of study, and they found that there was improved survival benefit if you could remove 75% of the tumor burden, if you had a favorable ECOG performance status, and there was adequate surgical resectability, and there was no central nervous system, bone, or liver mets. So clearly, cytoreductive nephrectomy does have a sort of significant survival benefit, but it's not for everybody, and people do need to be selected. An important point is that the mechanism of cytoreductive nephrectomy is still not known. Is it the reduction in the tumor burden simply allows for improvement in survival? Is it an immunologic mechanism that induces exposure of tumor antigens and strengthening the effect of the immunotherapy? Or is it the removal of secreted growth factors from the primary tumor that promotes progression of the metastasis? Regardless, times have changed. Since 2005, we have 7 new targeted molecular therapy agents that have been released and approved by the FDA as they demonstrate improvement in either progression-free survival or overall survival. This has greatly increased the available systemic therapies since the interferon and high-dose interleukin-2 era that were evaluated in the SWOG and the EORTC trials for cytoreductive nephrectomy. The mechanism of action of each of these drugs is very different from the immune therapy. They're all anti-angiogenic through what's eventually downregulation of the hypoxia-inducible factor. There are 5 new therapies here. Bevacizumab, which is a monoclonal antibody targeting the VEGF receptor. There's a Sunitinib, Sorafenib, and Pazopanib, which are combined VEGF receptor and PDGFR receptor inhibitors. There's a new systemic therapy on the market released 2012 that's more selective for VEGFR. And then as well, there's the mammalian target of rapamycin inhibitors, everolimus and temsirolimus. All of these have demonstrated improvement in some way. A key distinguishing factor in these is that they're primarily cytostatic. They're not cytotoxic. If we look at the data from the first-line randomized controlled trials comparing them to immune therapy, we notice that all of them demonstrate improvement in progression-free survival. You notice only temsirolimus is the only one that has significant overall survival benefit, although the other has trends towards it. And this is in the high-risk category. So the point I'm making, would it be fair to consider the same paper, cytoreductive nephrectomy, has overall survival benefit in this era with a whole new medications with a different mechanism of action and improved benefit? Well, let's take a look at the first trial. I won't go through all of them, but the first trial of the systemic targeted therapy, Sunitinib versus interferon alpha in the metastatic renal cell carcinoma. They had approximately 700 patients. They demonstrated significant improvement in progression-free survival. You notice that there was an overall survival benefit. It wasn't significant with a p-value of 0.051. An important point is they only had an objective response rate in 47% of the patients on Sunitinib. When you look at this population, there were 647 patients who had a nephrectomy and 77 patients who did not. So you could argue that the targeted therapies in this era are only proven in patients with in a pre-nephrectomized patients population. So what is the effect of systemic therapy on molecular targeted agents on cytoreductive nephrectomy survival? We don't have any prospective or randomized controlled data yet. Here's data from the BC Cancer Agency, Edmonton, Calgary, Toronto, Harvard, Cleveland. They're all conglomerated in a multi-institutional retrospective review. They reported on 314 patients with metastatic renal cell carcinoma treated with either Sunitinib, Sorafenib, or Bevacizumab. 201 of these underwent cytoreductive nephrectomy. They were all targeted therapy naive at the median start time when they resumed their therapy after the nephrectomy was 5 months post-surgery. Cytoreductive nephrectomy was independently associated with improved overall survival, having a median overall survival of 19.8 months compared with 9.4 months to those who did not undergo surgery. The benefit was marginal in patients with poor prognostic group. Now this is retrospective data, it's a pre-selected control group, and this is undoubtedly a biased population. If you take a look at the demographic data, here's the clinical and pathological data for those who underwent surgery compared to those who did not. Those patients that underwent cytoreductive nephrectomy were younger, have better performance status, were more likely to receive sorafenib, and were less hypercalcemic. However, they had a longer time from diagnosis to systemic therapy and had more sites with metastatic disease. Each of these subgroups demonstrate improved overall survival in the nephrectomy group when you look at them independently. Those with poor risk stratification based on lab data and poor performance status only had marginal benefit. The Cleveland Clinic retrospectively reviewed their patients from 2005 to 2008, so this is in targeted therapy era, who underwent debulking nephrectomy followed by Sunitinib, Sorafenib, or Bevacizumab. They only had 46 patients included. The median diameter of their tumors was 10 centimeters. They looked at the median fraction of tumor volume removed. And what they found that is if you removed greater than 95%, you had an overall survival benefit compared to that expected around 2 years. But if you do not remove greater than 90% of the patients, obviously these are patients with a bigger primary tumor burden and probably more advanced disease, but their survival benefit was minimal. So I've presented primarily retrospective data, and obviously there's some arguments against it. Some argue against it, prospective benefits. Some argue that the only proven benefit of cytoreductive nephrectomy is in the prospective era, and then treated with interferon. And this doesn't apply, given different mechanism of action. My arguments against is that the only level of evidence we have in cytoreductive nephrectomy is supportive. Retrospective data supports evidence in the current therapy, and targeted therapy is only proven in the nephrectomy population. Some state that the survival benefit is modest. Why are we subjecting these patients to massive surgery? I agree, there is a modest 5-month improved overall survival given significant morbidity of surgery. Surgery is not for everybody, and people need to be pre-selected, but in the vast majority of patients it will offer benefit. They state that there's every now and then there's a case of complete response with the primary tumor. Well, from our data from the New England Journal article, we noticed that there's only a 30% objective response rate. Not everybody's responding to targeted therapy, and it's not the holy grail. And they say that systemic disease progression may occur in the postoperative period. This is a valid risk. It needs to be validated. We need to compare the risk of progression to metastatic disease when it can be controlled with targeted therapy. And lastly, there's an argument saying that patient may not ever get their systemic therapy after they undergo surgery. If you look at the SWOG and the URTC trial, only about 5% of the patients did not get their systemic therapy after cytoreductive nephrectomy. So this is only a small portion of the population. So we need randomized control trial. Currently, the Carcinoma trial is ongoing. It's comparing nephrectomy with adjuvant sunitinib versus sunitinib without nephrectomy as first-line therapy. This is the same model design as that done in the temsirolimus in 2001, and we're awaiting current results. Quickly to summarize, cytoreductive nephrectomy is a randomized controlled trial from the data from the interferon setting. It's the only randomized controlled trial we have. Retrospective data is supportive. The benefit of targeted therapy is primarily shown post-cytoreductive nephrectomy or nephrectomy. And cytoreductive nephrectomy should be performed in all suitable patients with resectable disease and still the gold standard. There's a subset of patients where the risk and morbidity of cytoreductive nephrectomy may outweigh the benefits, and we're awaiting level 1 evidence. That's cytoreductive nephrectomy. I'd like to move on to a second scenario. This is case number 2. This is a 54-year-old female who presented with significant renal mass, tumor thrombus above the diaphragm. She had loss of border between her liver and her kidney, and multiple chest lesions. She had an urgent biopsy. This revealed clear cell renal cell carcinoma. She had intermediate risk disease, and her ECOG performance status was actually fantastic considering the extent of her disease. Her tumor was considered unresectable. So the next question is what should we do? CUA recently released their consensus statement in the CUAJ this summer. This is similar to that released by the AUA or other agencies, the EAU. If you look at this particular patient, she's an untreated patient with good intermediate risk disease. Her level 1 therapy is sunitinib, bevacizumab, or pazopanib. And other patients, depending on their risk stratification or whether or not they've received prior targeted therapy, it will change their second-line therapy. So this patient was given 2 cycles of sunitinib, and you can see she had a massive response. The multiple chest lesions were no longer evident. The tumor thrombus regressed. You see that her primary tumor has decreased in size. You can now detect a border between the kidney and the liver. And at this point, she was declared resectable. Now, the idea of resectable versus unresectable, it's a difficult concept. Everyone will have their own line. It's based on radiological assessment and how you feel once you've performed your laparotomy and are moving forward. But there's certainly imaging features on radiology that can lead you whether or not something is resectable or unresectable. So this is a scenario, brand new to urology, in renal cell cancer. Currently, most surgeons would look at this now and say, well, we can cut it out, let's cut it out. That's what the data shows. But good, strong data isn't there. We need to look at this, and that's what I'm going to do for the next couple moments here. In this patient, radical nephrectomy was performed. She had no active tumor in her tumor thrombus or in her kidney. It was all necrotic. An important question, is nephrectomy post-targeted therapy, is it safe? Chapin in 2001, European Urology, released his retrospective data on 173 patients. He compared 70 patients who underwent targeted therapy compared to 103 patients who had an upfront cytoreductive nephrectomy. Given that it's retrospective data, a large number of therapies were used. The majority was bevacizumab and erlotinib, and then just below that, bevacizumab on its own, This may be because the erlotinib ended up showing no significant benefit on phase 2 data. But they looked at their complication rate. If you look at their any complication rate, they had no significant differences for that, for major complication, for major factual dehiscence, DVT or PE. They did notice an increased risk of late complication. 2 of these patients, 14 total in the population, had a complication greater than 90 days out. 2 of them had chylous ascites. Both of them were in the targeted therapy group. As well, there's concern for superficial dehiscence and wound infection. There's phase 2 trial data out there on effective sunitinib in primary renal cell carcinoma and the facilitation of subsequent surgery. This is patients with biopsy-proven renal cell carcinoma with tumors that were deemed unresectable. They tried to give some parameters for this. They tried to say greater than 15 centimeters, bulky lymphadenopathy, advanced venous thrombosis, and proximity to vital structures. However, this is still up to surgeon interpretation. Regardless, they were given sunitinib, 50 milligrams. They got 3 cycles. And those patients who underwent were re-imaged. Those patients who had resectable disease underwent surgery. If they had no evidence of disease after their surgery, they stopped their sunitinib. And then other than that, if you did not have any response, you stayed on sunitinib or changed therapies. Or if you underwent your surgery but still had residual disease, you maintained on your therapy. Here's the example they provided for a patient that they deemed from unresectable to resectable. I have to agree with them. In the picture on the right, that's pre-therapy. The tumor is completely circumferentiating the aorta. You can't see the IVC in there. The tumor looks nasty. After therapy, it looks like a nice, simple laparoscopic radical nephrectomy. It looks great. So they had 30 patients. They had 35 total tumors. 19 of their patients originally had distant Mets. The majority of their tumors were clear cell carcinoma. What they found was they did notice a significant decrease in their median tumor size. They had 22% decrease in size. This is obviously in comparison to the primary tumor. The patients with clear cell histology and also the patients treated with sunitinib had better response. They were able to treat 17 of these tumors after targeted therapy compared to 18, and they deemed that they had no increase in complication rates and that it was safe. The data is minimal on this topic. The numbers are small. I found 3 trials, 2012, 2010, and 2010, all phase 2 or prospectively followed patients. They demonstrated that patients who had unresectable disease that went on to resectable, somewhere between 30 and 43% of the patients were able to undergo their nephrectomy. That 13 is different from previously because the numbers before were tumors resected versus the number of patients for Reza. So that was primary tumor. What's the effect on the level of the tumor thrombus, and does this have any effect on the level of the caval thrombus? Here they evaluated 25 patients treated with sunitinib as first line in approximately 12 of them. The majority of these patients had level 2 thrombi. However, some people had up to level 4. What did they notice? They noticed that 7% or 7 patients, 28% had an increase in the height of the tumor. 7 patients did not have any change, and 11 had a decrease. 1 patient had a change of an operative approach as a result of the preoperative systemic targeted therapy. So in summary, cytoreductive nephrectomy after targeted therapy, you'll notice a modest decrease in size. The majority of patients, will have regression of the tumor as opposed to progression, and about 30 to 43% of the patients may go from being an unresectable disease to a resectable disease. As a result, when start targeted therapy, if it's unresectable, it's worth a re-imaging at 2 or 3 cycles later, and it's safe. There is a slight increase in wound complications postoperatively. I'd like to move now to my third case, 54-year-old male from northern BC. This was an urgent referral. This patient had a large 18-centimeter renal tumor. He was morbidly obese. He weighed 486 pounds. He had tumor thrombus up to the level of hepatic veins. He had 2 hepatic lesions. You can see the lymph node compressing on the contralateral renal vein. Not a favorable resection. So what do? This patient was actually underwent the Monday afternoon, the once monthly review with the medical oncology that they have here at VGH. So any difficult patient, it's worth bringing up to this conference and discuss it with radiology, medical oncology, and urology. This patient was enrolled in randomized trial, and he was randomized to the preoperative Sunitinib arm. He had about the best results you could possibly imagine. His primary mass reduced in size from 18 to 12 centimeters. His tumor thrombus reduced back to the level of the renal vein, and the liver lesions had complete regression. This man underwent radical nephrectomy, thrombectomy, and retroperitoneal lymph node dissection by a chevron incision. This was not an easy surgery by any accounts. Dr. So was allegedly in there up to his armpit trying to get the tumor thrombus removed. But he had a phenomenal result. He had 4 days in hospital, no complications, no wound complications. He had Fuhrman grade 3 disease, but his margins were negative. And the guy's alive to this day, no evidence of disease. His scar showed only necrotic, his primary tumor demonstrated only, or his lymph node tissue demonstrated only necrotic tissue. So he had a fantastic result. Is there any role for placing patients on targeted therapy in the neoadjuvant setting? Some people would argue that preoperative systemic therapy may eliminate micrometastatic disease. Primary tumor downstages may decrease surgical morbidity. It may allow for nephron-sparing surgery, some people account, and it may convert an open case to an MIS case. And evidence of response to therapy from the tumor resected can potentially influence further therapy selection if they have disease recurrence or if they have residual disease. Why not? Well, the tumor may progress locally, regionally, or systemically on targeted therapy. The tumor may progress while on break from treatment for surgery, lose your chance of cure, and toxicity may increase the morbidity of the surgery. Just as many cases of regression, there's cases of progressions. Here's 2 patients reported by Bex in 2010 who were placed on neoadjuvant therapy for originally resectable disease, and they ended up having unresectable disease. The one patient on the right had such a significant tumor thrombus through the liver, into the heart. She had cirrhosis, ascites, she had congestive heart failure, and was unable to go for her nephrectomy. The patient on the left had significant involvement in the contralateral renal vein, contralateral vessels, was progressing, and had a declining performance status and did not undergo her surgery. Unfortunately, the numbers are small in the neoadjuvant setting. Currently, there are randomized controlled trials. Okay, I'll get to that particular trial and why we're having difficulties with the number. But for the time being, it's important we look at the neoadjuvant data. In 2010, Cowie published results from his non-randomized, open-label, prospective pilot trial evaluating the use of sorafenib in the preoperative setting in patients with clinical stage 2 or greater renal cell cancer. Inclusion was radiologically suspicious or histologically proven stage 2 renal cell, ECOG performance status of 0 or 1, and these patients had to have a planned nephrectomy within 4 weeks to be enrolled. Patients who required a more urgent surgical accommodation for symptoms or bleeding were not enlisted. One patient had TCC postoperatively, another one had liposarcoma. They were included in the safety analysis, but they weren't included in the primary response analysis. The dose of sorafenib was variable, and the median time off therapy was variable, or the time off therapy was variable, with a median of 3 days. 17 of their patients had localized disease, and 13 had metastatic. The primary had clear cell pathology again. In the graph on the right, we see a waterfall plot which evaluates the size of the primary tumor after targeted therapy, or the change in size of the primary tumor after targeted therapy. The median tumor response was a loss of volume of 9.6%. You notice 5 patients did have tumor growth. This did not meet RECIST criteria of a greater than 20% growth or a 30% decrease in size, which would have been a partial response. But of their 5 patients who had growth, no patients progressed to unresectable disease, and there's no progression of the cable thrombus, and it didn't meet RECIST criteria. 93% of patients had stable disease. 4 patients were downstage from T2 to T1. There's no complications of dehiscence. 1 patient had superficial wound breakdown, and 1 patient had a perioperative MI. So it was safe. It did have a significant effect on the primary tumor. clinical significance shown in this data is limited. There was another phase 2 PreSurgical feasibility study of bevacizumab in untreated patients with metastatic renal cell carcinoma. Untreated patients with primary tumors that were considered resectable were enrolled. They were given, they had 50 patients. They gave them 2 4-week cycles of Sunitinib. They were then restaged. Again, there was a mix between bevacizumab and Urological, or just the bevacizumab. And patients who had progressive disease or declining performance status had their nephrectomy deferred. In this intermediate and poor risk prognosis patients, the progression-free survival was 11 months. And this improved on the pre-study determined overall survival of 4.8 months. This number came from the 2006 phase 3 randomized controlled trial of bevacizumab. And the median overall survival improved to 25.4 months, which is similar to that in the randomized trial. Unfortunately, they did not separate their results for those who had nephrectomy versus those who didn't. They did their survival analysis for everybody as a group. They did do a multivariable analysis and found that improved overall survival was seen in those with a normal LDH and with those who received nephrectomy, which would be expected as per the trial design because these patients are pre-selected as the ones that will respond to therapy. There are no significant differences among groups among either progression-free survival or overall survival or overall response rate. When you compare them to the randomized controlled trial data in 2006. Patients who did not undergo a nephrectomy didn't undergo because of either radiographic progression or functional decline after the first restaging signs. But the million-dollar question still remains: would these individuals have had better outcomes had they undergone cytoreductive nephrectomy, or is this simply the pre-selected group who are responding to Sunitinib who will likely have a better prognosis treated with targeted therapy? The total data on overall survival in the literature is minimal. In order to improve numbers, Powell's combined 2 single-arm phase 2 prospective study evaluating upfront Sunitinib prior to nephrectomy. They had untreated, newly diagnosed, biopsy-proven metastatic renal cancer. They gave them either 2 or 3 cycles. And post-nephrectomy, if they continued on Sunitinib until they had progression. So all patients got Sunitinib post. Patients with symptomatic progression prior to nephrectomy did not undergo the surgery, and they were switched to a second-line therapy. They originally had 66 patients in their trial. 47 of these were able to undergo a nephrectomy. 19 did not. Of these, 12 progressed. Patient choice was 5. Now, they included here under patient choice that one patient committed suicide. I don't know if that's fair, but patients were having either anxiety issues, or a potential here is that they were having a fantastic response and didn't want to undergo their surgery. Of the patients that did undergo surgery, some patients, 42%, did not have progression post. Their overall survival was improved at 15.2 months, and they had a progression-free survival of 6.3 months. This is much lower than that described in the initial phase 3 trial, originally described by Motzer. They noticed in that group an overall survival greater than 2 years. However, we can't use them as a direct comparison. This is a pre-selected group. And they conclude that the overall survival is comparable. When you compare it, the question remains, is those responders, are those simply the pre-selected responders that will respond to their targeted therapy that are just getting a cytoreductive nephrectomy, and what is the benefit of the nephrectomy? Well, we don't know. Currently, there's a phase 3 randomized controlled trial going on right now. This is the CirTime Trial. We're currently enlisting patients at VGH. And it may be a while before this data is released. If you look at an update in 2013, they're going for 458 patients. They only have 64. Part of this issue may be what we discussed in the neoadjuvant setting. Some patients may be progressing on disease and be switching therapies, or some people may be responding and not wanting to go under surgery and pulling out of the trial. And it's a difficult trial to accrue for. So any patients that you do see that can meet this criteria, please send along for discussion to the VGH group or to the BC Cancer Agency, and they'll take care of it. In summary, pre-surgical targeted therapy in unresectable disease, patients with unresectable disease should be started on targeted therapy and reevaluated. The response to therapy is associated with improved overall survival and may help risk stratify. And there's no role for neoadjuvant therapy outside of clinical trials. Significant risk of progression does occur, and there's a lack of objective response in too many patients to proceed. A quick note on adjuvant therapy. Pre-targeted therapy, there are 11 trials, all negative. Currently, there's 5 randomized trials. For targeted therapy, 4 have finished accrual. We're awaiting their results. The last one's still ongoing, but we have no further results. In summary, if it's possible, cut it out. Cytoreductive nephrectomy is recommended and likely still has benefit in the targeted therapy era. If you can't cut it out, try the medicine, the targeted therapy, then wait and see if you can cut it out, and if you can, do it. Targeted therapy does offer a significant benefit in downstaging metastatic renal cell carcinoma in some patients and allows for more patients to undergo resection of the primary metastases if it's initially unresectable. It's safe and likely beneficial, and don't delay cutting it out. Neoadjuvant therapy currently has no roles and has a mild increase of complication, and not all patients are responders with only about a 30% overall response rate. However, optimal drug use, timing, dose, and length of course in either neoadjuvant or adjuvant therapy is still yet to be determined. Lastly, a quick plug. Always consider randomized controlled trials, and the monthly renal cancer rounds are held at VGH, Urology, Medical Oncology, and Radiology, and all patients are always welcome for discussion. So I'd like to thank Dr. So for his help with the talk. Dr. Black provided a case and some advice, as well as Dr. Coleman's Thank you.